Hi, I'm Dr. Chiu, lecturer in AUCMS and also Vice President of National DFD Alliance of Malaysia. I was one of the invited speakers for recent ECTA third biennial meeting, New Technology in Colorectal Surgery, which was held in Singapore from 6 to 9 of December 2013. The topic given to me was New Understanding of Causation of Anal Fissure. Unfortunately, the recording was not clear. Due to good demand, I repeat the recording with elaboration, hope to benefit more people, especially those who are suffering from the related problem. Anal fissure is a tear at anal nerve. Most of it located at 6 o'clock position or the posterior position, remaining 10% at 12 o'clock position. But majority of the sufferer of anterior anal fissure is female. It occurs in practically all ages, including multiparous elderly women who has hypotonic anus. The symptom of anal fissure is just practically like hemorrhoid clinically: pain, bleeding, pruritus or itchiness, swelling. It can be superficial tear or deep. The deep one usually shows some sign of chronicity like proximal hypertrophic scar and distal sentinel part. The cause of it is actually a big debate, but initiating factor that is beyond doubt is due to overstretching by hard stool or even diarrhea. Fissure is guided by sacrococcygeal bone, the curvature. Beyond the tip of the bone, it started to push down on the pelvic floor. So naturally, by physics, it will overstretch the most posterior aspect. This answers why more than 90% of the anal fissure located at the back of 6 o'clock position. This is a picture of MRI of puborectalis, urethra, vagina, and anus. When the puborectalis is squeezed together and is strained for defecation, is strained together like this. And that is the reason why constipation are closely associated with sexual dysfunction and urinary incontinence. With the puborectalis overstretched by constipation regularly, how can it perform the function of squeezing the urethra and the vagina, which is smaller and small toward the front? During defecation, feces push down the puborectalis backwards and downwards. That repeated process lead to laxity of the puborectalis muscle, leading to so many associated problems. Why typical anal fissure practically only on anterior or posterior? Because when a cylinder thing enter the anal canal, vertically it will be round. When it go in a slope, it will naturally, by physics, it will go anterior-posterior stretching. Why anterior fissure is significantly more among women? The answer is very simple. Because in men, there is a prostate, but in the woman, there is no protection in the front, lead to overstretching to the front. Study found not only anal fissure, but also hemorrhoid are associated with anal spasm. So, actually the spasm can be a result of the symptom. Itchiness, pain, swelling is sufficient. Physiologically, it's sufficient to cause a spasm. Based on the principle of spasm, lateral sphincterotomy, based on the understanding of the spasm, lateral sphincterotomy is performed to release, to decompress, to improve the circulation. But the principle is not being utilized in the treatment of hemorrhoid. In fact, it is what we do is just opposite. In this PPH, we actually excise together with the blood vessel. In Doppler guided arterial ligation, the artery and the vein together has been identified and ligate. That solves the hemorrhoid, but it doesn't lead to the formation of anal fissure. This means to say circulation at the anal region is not a problem. So it is rich in the blood supply, rich in anastomosis, so it shouldn't have any ischemia to lead to anal fissure. Then, study also found 6 o'clock position to have lesser number of arteriole and also lesser detection with Doppler flow meter. This is actually a normal physiological or anatomical finding. At the midline, where the two systems of arterial system ends, it ends with capillary. Capillary is the area where the blood flow will be slower to permit proper perfusion. Is chronic anal fissure ischemic in nature? A typical ischemic ulcer should be gangrenous, not easily bleed, no evidence of healing. But what we find in anal fissure is just opposite. It's healthy tissue, easily bleed, and overgrow with healing tissue. Histopathology found the age of the anal fissure and also sentinel pile is actually a pile of healing tissue. That means it has a healing ability. If we stick to ischemic and spasm theory, we cannot explain why hypotonic anus also suffer from anal fissure and why women suffer from anterior fissure more than men. If we put them together, constipation can be due to whatever reason. No matter what is the reason, there will be straining. Once we strain, the pelvic floor will descend. The descent of pelvic floor will bend the rectal, lead to formation of obstructed defecation. So constipation can be of whatever type but lead to the formation of obstructed defecation and the vicious cycle carry on. This vicious cycle is beyond doubt. There's a lot of papers on supporting this since 1960. Actually, this is the first person to relate constipation, straining and descent in a vicious cycle is Professor Park since 1960. Woman has more descent of pelvic floor because of pregnancy changes and also parity, that means the birth trauma. The pregnancy changes mean the physiological changes during pregnancy, like hormone, the progesterone hormone relax the pelvic floor. With the pelvic floor relaxed, with traumatized pelvic floor, it descends. Descent pelvic floor will lead to anal mucosa eversion, exposure of anal hemorrhoidal bed more. With the straining, the hemorrhoidal bed will engorge to become hemorrhoidal vein. This green indicate the physiological changes during pregnancy that increase the chances of hemorrhoid in pregnancy. Constipation or diarrhea may overstretch and cause a tear, that is anal fissure. Anal fissure is the commonest cause of anal bleeding and also the commonest complication of constipation. And the anal fissure lead to the pain and spasm that worsen the constipation again. After delivery, episiotomy wound may be stitched, but during straining for defecation, the straining will descend the pelvic floor and also widen the levator hiatus. That will lead to broken or tear down of the stitch of the muscle, lead to dehiscence, weakening of pelvic floor, irreversible weakening of pelvic floor that is responsible for easy delivery. After the first one, the second one will be easier, and the third one will be even more easier and easier. With that, sexual dysfunction also set in. And with pelvic floor weakened, sac pelvic floor lead to obstructed defecation. With the obstructed defecation, the woman has to strain more. The straining more actually damage the pelvic floor. The puborectalis more, the pelvic floor damage is more, and this explains the vicious cycle. That's why a lot of women after delivery, they started to have constipation and hemorrhoid problem and also anal fissure problem more. With aging and menopause, the pelvic floor continue to descend, continue to weaken. One day it will lead to uterus prolapse, rectal prolapse, and even bladder prolapse. And urinary incontinence are all part of this. If you look at the whole picture, the most important factor is actually descended perineum. Pelvic floor actually weakest at the most posterior part anatomically, because in the front there is two layers, superficial pelvic floor and deep pelvic floor, which is levator ani, but at the back it's actually exposed. Study also found that bowel dysfunction or constipation correlate exclusively with posterior aspect of pelvic floor support. So beyond the tibial-coccyx, feces start to push down, and that set down, that bend the passage, that contribute to obstructed defecation. And we know constipation complicate to a long list of problems. The top three are anal fissure, hemorrhoid, and pelvic organs prolapse. Even this author was telling, chronic constipation should be managed according to its etiology and guided by the best evidence-based treatment. If you treat anal fissure, hemorrhoid, and pelvic organs prolapse alone, is not going to solve the problem. This is what we are facing in the world. So, what is the cause of anal fissure? Overstretching cause a tear. That is the cause of anal fissure. This alone can explain why a young baby, a young children also suffer from anal fissure just by due to hard stool or big size stool and overstretch. But how about the elderly people with hypotonic anus? With hypotonia, with the pelvic floor weak, it sag down. Sag also predisposed to overstretching. So this will explain also why hypotonic anus suffer from anal fissure. So if we think lack of support, weak pelvic floor, lack of support is a cause, then support should help. Let us see how is there any evidence that support help patients? When a patient tells doctor, I need to support to assist my defecation, that is taken as one of the Rome 3 criteria in diagnosis of chronic constipation. This can also be interpreted as the world's largest evidence that patient benefited from a support. This is evidence. Assessment of women with defecatory dysfunction and manual splitting using dynamic pelvic floor magnetic resonance imaging. In this study, just by manual splitting alone, a big percentage of them improved significantly, including the constipation associated with it. Kegel exercise is another example where we try to tone up the pelvic floor, strengthen the pelvic floor support by using exercise. This has been widely promoted throughout the world. That means to say the support is well promoted and well accepted throughout the world. Anterior levatoplasty is a surgical procedure to strengthen the support of the perineum in front of the anus. That has found to be benefiting anterior anal fissure. This is evidence that anterior perianal support benefit anterior anal fissure. Retroanal levatoplasty is a surgery to strengthen the area behind the anus or anococcygeal part. That surgery itself is found to be beneficial for practically the whole range of pelvic floor disorder, including the constipation. Studies also found outlet obstruction secondary to pelvic floor dysfunction account for more than 50% of the total constipation in adults. This is actually the biggest problem. More than 50% lead constipation due to the obstructed defecation. So this is the main problem. Beyond the tibial-coccyx, it started to push down. This pathology may not be so prominent in our normal pathological X-ray or anything, because this is happen during defecation. With this, since this is a problem, the solution should be like this. So we have created a mechanical support to support it, the area. We call it colorectal bowel aid. What it does is just support, you can see, straighten the band passage, straighten the obstructed defecation. Obstructed defecation is one of the most important cause of constipation. With the support, it enhances the reflex mechanically without any side effect. This makes it probably the world's first mechanical laxative that we can confidently prescribe to women who is pregnant suffering from hemorrhoid, and also patients with end-stage renal failure where they cannot take too much of fluid or too much of fruits because of potassium and water restriction. And by having the support, it prevents the backward stretching itself. Easily explained how it will benefit the posterior anal fissure. Right from the beginning, we predicted more than 90% of the anal fissure will be benefited because of this mechanism. But today, we have clinical paper proven posterior anal fissure, selectively for posterior anal fissure, it benefits up to 100%. By having the support, it also prevents downward pushing of the pelvic floor during defecation that will protect the surgical site. Example, episiotomy. It prevents the stretching of the wound, allow the wound to heal better and stronger. Hopefully, it will be a very good preventive role in the related problem, including anal fissure and also the rest of pelvic floor disorder. So, management of anal fissure. For anterior fissure, lack of support will provide anterior perineal support. This can be performed even manually using hand. Posterior anal fissure, we can perform with posterior perineal support, and we recommend it's easier to perform using a toilet seat. So in conclusion, anal fissure is not actually a disease by itself. It is just a manifestation of a group of problems at the perineal region which share the common etiological factor. The factor are chronic straining for defecation or constipation, weakened and sagged pelvic floor. Defecatory perineal disorder is disorder of perineum which is etiologically closely associated with constipation, straining for defecation, and sagged or weakened pelvic floor. So in handling a disease, it's clearer for us to name the disease by the cause, not by the manifestation. But now, if you look at the anal fissure, it is just a description of the problem, attack. Look at the uterus prolapse. It's just a description of the uterus prolapse, but that is not. The uterus itself has no disease, but it's the mechanical support of it. The structure of supporting structure of that is actually the one has problem. So we know pelvic floor. Many pelvic floor disorder manifest the problem pertaining to rectum, uterus, reproductive system, and also urinary system, with constipation, sexual dysfunction, and urinary incontinence. Constipation patient could have learned how to manage themselves with oral counter treatment. Sexual dysfunction patient could have adapted to the life. They may even divorce because of that. But urinary incontinence actually make them shy away from society, isolate themselves. But when a day will come, the problem is so severe, they will go for surgery. Hemorrhoid, we may have a surgery to take away the hemorrhoid. But do we take away the disease cause? Same for the urinary incontinence. By this surgery, it takes away the symptom. But the problem of the weakened pelvic floor is still there, especially the posterior aspect. When the posterior aspect is still weak during the application, feces guided by sacrococcygeal, beyond that, they start to push down over there. When they start to push down over there, it will cause obstructive defecation, lead to the need of more straining is going to put the whole pressure, increase the burden on the surgical side. So this will logically increase the chances of complication. So by having a support over here, even though a very simple support, it should be able to minimize the burden on the surgical side. This will logically prevent or minimize the complication or delay the onset of complication. In summary, pelvic floor support is essential for normal functioning of anal system, reproductive system, and also urinary system. But the pelvic floor support is damaged by vaginal delivery, chronic straining for defecation, and the problem worsen with the aging, with age progress. When the pelvic floor damage, it manifests with so many things: urinary incontinence, frequent infection of urinary tract, sexual dysfunction, constipation, uterus prolapse, rectal prolapse, fecal incontinence, hemorrhoid, and so on. Over here, there are hundreds of surgical procedures over here, but none of them have preventive role. Take for instance, hemorrhoid, we just chop away the disease part, but without taking away the disease mechanism. Uterus prolapse, we may just take away the uterus. Uterus will not prolapse anymore, but rectal can prolapse, bladder can prolapse. So we are not treating the cause of the problem. Actually, we are treating the manifestation of the problem. So if you look at here, constipation is the cause of the damage of pelvic floor. Constipation also a consequence of the damage of pelvic floor. This means to say this is the center of the problem. Center of the problem, which is a vicious cycle, should be handled if you want to manage the problem, all these problems for long-term benefit. Thank you.